Dear colleagues, welcome to neurology lecture. Today we're discussing stroke and its management. Acute stroke is infarction in the brain, spinal cord or retinal cells attributable to ischemia based on pathological, imaged or other objective evidence of cerebral, spinal cord or retinal focal ischemic injury in a defined vascular distribution or clinical evidence of cerebral, spinal cord or retinal focal ischemic injury based on symptoms lasting more than 24 hours or until death and other etiologies excluded. Ischemic stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal or retinal infarction. Transient ischemic attack, TIA, are episodes of temporary and focal dysfunction of vascular origin, which are variable in duration, commonly lasting from 2 to 15 minutes, but occasionally lasting less than 24 hours. They leave no persistent neurological deficit. We may classify ischemia into transient brain ischemia, such as transient ischemic attack or cerebral hypertonic crisis. Brain ischemia itself, ischemic stroke. Intracerebral hemorrhage, hemorrhagic stroke. Subarachnoid hemorrhage, hemorrhagic stroke in subarachnoid space. And venous sinus thrombosis with the brain dyscirculation. TIA, brain ischemia, brain hemorrhage, subarachnoid hemorrhage, and venous thrombosis. Subtypes of ischemic stroke according to Toast classification are large atherosclerosis, atherothrombotic stroke, cardioembolism, small artery occlusion or lacuna stroke. Reasons according to these Toast criteria are macroangiopathy, cardioembolism up to 25%, microangiopathy 20%, other pathologies of vessels, concurrent diseases up to 7%, and unknown etiology 23%. We may classify risk factors into modified and unmodified. So let's pay attention to modified stroke risk factors and how to correct them. Primary prophylaxis is controlling vascular risk factors such as elevation of blood pressure, losartan more preferable than atenolol in patients with hypertrophy of the left ventricle, in blood pressure more than 140. Blood pressure more than 130 and 80 also should be corrected. Hyperlipidemia should be controlled by statins and diet. Smoking, quitting smoking reduces the risk of stroke twice within 5 years. Alcohol intake, alcoholism leads to angiopathies. Physical activity deficiency, hypodynamia is one of the risk factors that is growing associated with our development. Fruit, vegetable, fish intake, diet control reduces the risk. Body weight, reducing the body weight will decrease level of glucose, decrease level of blood pressure, and will decrease the risk. Postmenopausal estrogen therapy also. Non-modified risk factors include age. Risk increases twice each decade after 55 years old. Gender, male in earlier age and later, female. Low body weight at birth, less than 2.5 kilograms. Ethnic factors, for example, mostly affected black less Caucasian, less Latin American, and less Asian ethnic groups. Genetic factors. Risk is 30% high in patients with family anamnesis of stroke or myocardial infarction. Smoking. Even a simple doctor's advice showed in the trials to be effective in helping patients to quit smoking. To help the patient to quit, the doctor should ask about the length of smoking, evaluate the degree of nicotine addiction and the will of the patient to quit, helping the patient to build a plan for quitting smoking, arranging the date for the next visit, talking to the patient's relatives if needed. So if you haven't quit smoking yet, please consider doing it now. Strongly recommended smoking patients after stroke or TIA to quit, avoiding passive smoking, psychotherapy and nicotine substituting therapy. Alcohol. Patients with alcohol abuse and stroke or TIA should stop or at least decrease alcohol intake down to 2 shots per day for men and 1 shot per day for women. Do not recommend patients who haven't been drinking to start taking alcohol for prophylaxis, even though in some recommendations it may be mentioned. Which level of the blood pressure is considered increased? Systolic blood pressure more than 140 millimeters and or diastolic blood pressure more than 90 millimeters, systolic blood pressure less than 140 and or diastolic less than 90 during antihypertensive drugs. There is no target level. It is individual, but it is recommended to aim to reach systolic blood pressure less than 140 and diastolic less than 90, unless patients who are really addicted to high pressure may feel very bad. Then you will make this decrease very slowly. In patients with recent lacunar stroke, their decrease down to systolic blood pressure less than 130 millimeters is acceptable. Diabetes mellitus. All patients after stroke or TIA should be screened for diabetes mellitus. 3 tests are used. Fasting level after 8-hour break in taking food. Tolerance to glucose 2 hours later after taking 75 grams of glucose. And glycosylated hemoglobin, which shows us average glucose level within the last month. Diabetic patients after stroke or TIA are recommended to have blood pressure less than 140 and 85 millimeters. Excessive weight is a risk factor. Screening for obesity with body index measurements is recommended for all patients with stroke or TIA. In case of increased body index, recommendations for decrease of body weight indeed including rational nutrition recommendations and physical activity according to capacity. Rational nutrition. Limitation of salt to 2.4 grams a day after transient ischemic attack or stroke, which is approximately 1/3 of a teaspoon. Additional limitation 1.5 in case of hypertension. Mediterranean diet is recommended, which is rich in vegetables, fruit, whole grains, dairy products including low-fat, poultry, fish, olive oil and nuts. Will limit the consumption of sweets and red meat. And usually we do not recommend vitamin supplement unless it's indicated. Dyslipidemia. For high cholesterol, statin therapy with intensive lowering of lipid levels is recommended to patients after acute cerebrovascular accident of presumed atherosclerotic origin with low density cholesterol level more than 2.0 6, regardless of the presence of other atherosclerosis-related portions. It was demonstrated it is appropriate to prescribe statins at low-density cholesterol level less than 2.6 millimoles per liter. Diagnostic algorithm of acute ischemic stroke. Sorry for the mistake. Focal signs for supratentorial localization will include hemiplegia if the motor center is affected, hemianesthesia if the sensory center is affected or the pathways, hemianopia if the visual pathways are affected, or in case of thalamus opticus, dysphasia if speech centers are affected. For subtentorial localization, hemiplegia or tetraplegia, hemihypoesthesia, alternating hypoesthesia, alternative syndrome, cranial nerve lesion, pontine, peduncular, bulbar, pseudobulbar syndrome, if the brainstem is affected. General cerebral signs, transtentorial dislocation, consciousness impairment, meningeal signs, bilateral pyramidal signs, vital functions disorder, general cerebral signs. For dealing with stroke, we educate people the concept of time is brain, delays in hospitalization, slow down the recurrent, direction and transportation of the population. We need to constantly remind the ambulance doctors how important it is to transport within the therapeutic window, prompt recognition and immediate response to TIA stroke, immediate exit for urgent care, priority transport with notification of the hospital. The hospital is ready for the patient while the patient is on the way, immediate hospitalization to the intensive care unit, such urgent management as creation of recommendations for pre-hospital and hospital treatment of the patients with stroke using additional tests and scales such as an IHSS scale for evaluation of the severity of stroke. Emergency diagnostic tests in acute cerebral stroke include neurovisualization, CT scan or MRI scan, though we remember that CT scan can be negative within the first day sometimes, ECG for finding of the risk factors such as risk for cardioembolism, lab testing which will include clinical full blood count, prothrombin time, electrolyte composition, glycemia of the patient, C-reactive protein, seduction rate, biochemical analysis. Here is the example of MRI of a patient with stroke in the cerebellum. You can see the low density. Pre-hospital care basic therapy include correction of the respiratory disorders, bradypnea less than 12 minutes need artificial lung ventilation, and tachypnea more than 35, oxygen therapy if needed, blood pressure correction by lisinopril, labetalol, candesartan, correcting of water electrolyte metabolism, for example, hyposmolar solutions or physiological solution or glucose, brain edema and increased intracranial pressure will need head and elevation, relief of seizures by diazepam, 10 milligrams intravenously up to maximal dose of 80. Neuroprotection includes magnesium sulfates, glycine, Semax, Maxidol with antioxidant, cerebralizine as neuroprotector, citicoline as neuroprotector and antioxidant. Non-differential therapy of stroke includes adequate oxygenation, inhalation of oxygen, or mechanical ventilation, maintenance of systemic hemodynamics, for example, by vasotonic drugs, treatment of seizures, diazepam or general anesthesia, restoring electrolyte and acid-base balance by hypertonic solution, potassium, calcium, potassium and magnesium, asparagine, diuretics, dextrans, glucose with asparagine, alkaline solutions if needed, parenteral nutrition. Neuroprotection, primarily within 72 hours to save the zone of semi-shadow where the neurons are not dead, yet we are trying to save them, includes cerebral hypothermia if possible, glycine 1 to 2 grams, Maxidol 1 gram daily intravenously, tetrazoline 4 milliliters and Ringer's solution or glucose, Activigen, nootropic and vasoactive drug, nimodipine, calcium channel blockers, especially in hemorrhagic strokes, 32 milligrams per kilogram a day, intravenously. Statins, patient after atrial thrombosis or lacuna stroke or transient ischemic attack are recommended to receive anti-cholesterol drugs such as statins. Atorvastatin 20 to 80 milligrams a day, simvastatin 20 to 40 milligrams a day to decrease low-density lipoproteins to 2.5 millimoles per liter and lower. Antiplatelet drugs. Clopidogrel is 8% better than aspirin, effective for repeated strokes especially. I think it's 80. Warfarin is 67% better than aspirin. Yeah, clopidogrel is 80. And aspirin 50 to 325 milligrams daily after the first stroke, always recommended. Whom should we prescribe anticoagulants in case of arterial fibrillation and mitral stenosis? Echocardiographic signs of blood clot in the pulmonary atrium, of enlargement of the pulmonary atrium more than 55 millimeters, Purpose level of ENR 2-3. Mechanic artificial valve, biological conduit for patients with stroke or TIA in analysis before the valve conduit without indication for anticoagulants 3 to 6 months after implantation, long intake aspirin, more preferable than anticoagulants. Anticoagulant choice, vitamin K antagonist, warfarin, acenocomarol, new oral anticoagulants, only non-valve atrial fibrillation without rheumatic mitral defect of artificial mitral valve, such as dabigatran or rivaroxaban. For example, you can see how the scale evaluates the indication of risk factors. Secondary prophylaxis include high blood pressure with recommendation of aprosartan, indapamide, perindopril. In diabetes and hyperlipidemia, atorvastatin and simvastatin. Diet, weight control for secondary prophylaxis or repeated stroke once one already had happened. Caring of obstructive sleep apnea. We know that oxygen through CPAP should be given. Pentotheramin avale care and postmenopausal estrogen replacement therapy. Rehabilitation of patients after stroke is very important. Rehabilitation goals include restoring household capabilities such as mobility, self-care, performing of simple household chores, restoration of employability if possible. We should try to return the patient to profession. in the presence of contraindications or inability to perform previous job skills, retraining, if possible and if desirable. The preservation of the social activity and importance of the patient, which means a lot, especially since many of these patients will have depression. Prevention of recurrent stroke and complications, which of course will slow down the rehabilitation. Evaluation of severity by NIHSS scale includes determination of respiratory lung function, early signs of dysphagia, preferably using test of assessment of swallowing evaluation. We ask the patient to make 3 swallows of water in presence of doctor. Evaluation of concomitant heart disease, measurement of blood pressure and heart rate, and determination of blood oxygenation. Kinetic motor function restoration. Method of fixed stretching. Extremities fixed with splints and plaster bandages. Method of manual stretching, orthopedic stretching of the muscles with passive kinesiotherapy, which decreases the spasticity and slows down or avoiding the contracture forming. Active and passive physical therapy, very important. Electrical stimulation for paralyzed muscles by programmed electrical charge. Warm procedures such as paraffin bath or cryotherapy if needed, and massage. Speech restoration. Speech is one of the few functions that can recover after stroke. Sometimes this process takes more than 1 year or 2 years. Speech therapy helps the patient to strengthen the muscles of the tongue and the face. It helps to relearn how to pronounce sounds and syllables, and for patients with dysarthria, it's recommended to practice with a mirror. Restoration of chewing and swallowing. In disturbance of consciousness of the act of swallowing, feeding is though probed with special mixtures. If during the treatment swallowing problems continue, the gradual transition from probe feeding to normal is carried out. For example, we try not to give the food of different density separately. We give mashed potato soup and separately meat or sausages, not mixed, because they have different texture, if you can say so. Bowel and bladder disturbance includes diet, controlling of the water regimen, medications, of course, diapers, urine and colostomy bags, enemas, if needed. Judging reasoning and behavior disturbances, courses of nootrops, neurometabolic drugs in some cases improve cognitive function of the brain. Treatment of psychological problem is done with the help of psychologists or psychotherapists. Group or individual psychotherapy is very effective, especially combined with the drugs, and especially since there is depression. So thank you very much for the attention. This is an important question, and if you have any questions, please forward them to your teachers during the practical class. Please take care. Bye-bye.